Today I'm doing patient exams, and young Ellie has shown up. She's 12 years old, and one thing I notice as I do my exam of the oropharynx is that Ellie has a bifid uvula, and that's important for dentists to pick up. It could sometimes be a sign of a submucous cleft, and the main thing is that if a child has large adenoids, this is one contraindication to removing the adenoids, because if you do, you could create a fistula or an opening between the nose and the mouth. Okay, so let me show you that. Can you let everyone see that? Just open nice and wide. Okay, big R, say R. If I just move the tongue out of the way there, can everyone see that? So that's a bifid uvula, right? Now this young lady had her tonsils out, is that right? I think when you were younger, but the ear, nose and throat doctor didn't take out the adenoids. Now can you see one of the, just put your chin up in there for me, one of the things you'll see is a narrow palate, okay? So my job as the orthodontist then is to widen the palate, and that will help the nasal airflow. Obviously here we're doing it to make room for the canines as well. Just give me a big smile, okay? So other things you see in these sort of situations, and there's a syndrome which I'll discuss the signs and symptoms. But remember, for a syndrome to occur, there need to be a number of factors. So this could be just a variation of that, right? The main thing is these children, when they speak, tend to have more of a nasal tone, right? Because like, well, can you say for me? Can you say banana?
Banana.
Yeah, say it again.
Banana.
Yeah. So the banana. What's that? Say banana.
Banana.
Yeah. So banana has a bit of a nasal tone to it, and that's one of the other things that we look at. So the summary is, when you're looking at a child who has a bifid uvula, you really should seek an ear, nose and throat opinion to rule out some of these syndromes. And there's links with Marfan syndrome, etc., etc. But I'll go through more of those in detail. But at this stage, I think dentists are the number one people who will pick this up. And if we look at the X-ray here, you can see the class 3 jaw tendency, not because the mandible's too big, but the maxilla's not big enough, and that's related again to these factors. But look at the adenoids. Now normally you'd remove those because they're blocking the airway. But if you do, in this particular syndrome, you're going to create that problem. And so that's why here we have other ways of working around that, so that we still leave the adenoidal pad and develop the upper arch, and improve the breathing and the speech. But these children tend to have a history more associated with speech pathology. So for the speech pathologists that are listening, that's another thing to look for in the mouth, the bifid uvula.